Hi, my name's Audrey Tan. I'm presenting a radiology case report on scoliosis. So what is scoliosis? According to the Scoliosis Research Society, scoliosis is a lateral curvature of the spine greater than 10 degrees. The word scoliosis is derived from a Greek word meaning twists and turns, and 80% of scoliosis cases are considered to be idiopathic in nature, meaning they don't know what caused it. To introduce our patient, she is an 18-year-old Asian female who was seen in the musculoskeletal clinic at Fresno State. Her chief complaint was upper and middle back pain that she had had off and on for 2 years. She was diagnosed with the scoliosis 1 week prior to her first physical therapy appointment and when she came to the health center. She was a full-time student studying nursing, and she had had no prior medical treatment. She did not know she had scoliosis before that doctor's appointment. And she's also not taking any medications. She is a healthy young adult. Currently, she was training for a marathon, her first marathon, and her goals for physical therapy were to manage her back pain and to understand her scoliosis a little better. She described her pain in her upper and middle back as dull and achy. When asked about the pain level, she described it as a 4 of 10, 10 being the worst amount of pain ever. And at worst for her, she experienced it as a 4. At the initial evaluation, when asked about pain, she had none. She answered 0 of 10. Aggravating factors for her back pain were standing for long periods of time, sitting without back support, any kind of cold weather or sitting in an air-conditioned room. Alleviating factors, things that made her back feel better, were sitting with back support and lying down, supine. Musculoskeletal problems were the only problems that were suspected. She did not have any numbness or tingling, no nerve problems, no respiratory or breathing problems either. A posture analysis was done. From the anterior view, her right shoulder was higher than her left. Also, her right hip appeared higher than her left. From the lateral view, she had very minimal forward head posture, otherwise good alignment. Spinal range of motion was taken with a tape measure. Both the flexion and extension showed nothing unusual. She had good flexibility, getting her fingers all the way almost down to the floor, just 1 centimeter away. Extension, again, 39 centimeters from the sternal notch to the plinth, so she's lying down prone and asked to press up. No pain with either movement. Lateral flexion, so side bending, there was a difference. She could go much further on the left side than the right. And with rotation, she rotated further and also easier, she reported, towards her left side rather than the right side. I performed a scoliosis check, meaning that I had her stand and then bend forward, flex at the hips, and I looked from her backside to see if the back curved. So there oftentimes is a rib hump that's associated with scoliosis. And she did have 2. One rib hump appeared near the right scapula, and then a second rib hump appeared near the left lower rib cage, indicating that there's rotation in the spine, which occurs anytime there's lateral curvature as well. And so judging from, again, the locations of the rib humps, I suspected she had a right thoracic, left lumbar scoliosis. She had imaging done, radiographs done, when she first visited the doctor. I did not get a copy of the radiograph until her second visit, but this is the actual radiograph. It confirms a diagnosis of right thoracic, left lumbar scoliosis, each curve measuring approximately 36 degrees, which classifies her scoliosis as moderate. The thoracic curvature was measured at 36.624 degrees, and the lumbar scoliosis was measured at 36.785 degrees. So again, very balanced. Probably that would be why she wasn't having as much problems up until the point of her coming in. This is some more imaging that I found online because the AP view was the only view that was taken of the radiograph at school. So this is a lateral view as well, which is oftentimes helpful to determine amounts of rotation in the spine that you can't see necessarily with the AP view. And then this is AP view with lateral flexion. So they take pictures in left and right side bending to see if the spine actually changes at all with the lateral flexion. And those, again, were not taken with my patient. So as part of the evaluation, I determined that she had right thoracic, left lumbar scoliosis by looking at the physical findings of, again, the right shoulder and the right hip both appearing higher, rib humps both in the right thoracic and left lumbar region when she bent forward, and then just actual palpation of the spine itself, feeling when it went to the right and where it went to the left. That plus the diagnostic imaging, the AP view radiograph, again, led me to the diagnosis of right thoracic, left lumbar scoliosis. So prognosis and plan of care, I believe she was a good candidate for physical therapy. She was young, her back was very pliable, and she was also very motivated to manage her back pain. She was a nursing student. She knew that she would have to be doing a lot of physical activity with her major and hopefully career. So she did want to get make her back stronger and, again, lessen pain. I did educate the patient that the physical therapy would not change her structural scoliosis, but it certainly could help minimize the effects of the scoliosis, minimize pain, and also create more muscular symmetry in the body. Goals for physical therapy were to decrease her back pain at its worst from a 4 of 10 to a 1 of 10 in 4 weeks, to also decrease the frequency of back pain she experienced in the 4 weeks. Also, the patient will successfully demonstrate a home exercise program, and she would also be able to demonstrate and put into practice more symmetrical sitting and standing posture. So treatment, again, education about not exacerbating the scoliosis while sitting and standing to decrease pain and to also improve her postural symmetry. We worked with therapeutic exercise to stretch the tight muscles of the back and also strengthen the weak muscles to improve muscular symmetry and also to decrease pain. The other thing we did was traction for the spine and to help decrease the back pain. I taught her how to do it for herself, and I saw her twice a week for 4 weeks. So at discharge, a patient reported no incidence of back pain since starting physical therapy, which was terrific. She also successfully ran a half marathon about halfway into our work together, and she experienced no back pain whatsoever. Her legs were tired, but she didn't have any back pain, which was great. When asked about rating the pain at its worst, even at discharge, she still rated it a 3 of 10, but then she also reiterated that she actually did not experience any back pain while working with me. So in some ways it's successful, even though the goal itself was not met. And then also the patient reports successfully sitting without crossing her legs to promote spinal symmetry. Here are the spinal ranges of motion measurements, both at initial evaluation and at discharge. Flexion extension did not change much, but you can see the lateral flexion did change. So before it was 32 and 35 centimeters, a big difference, a 3 centimeter difference from side to side. But you can see at the discharge, she was actually even. So the left side and right side lateral flexion were even at 37 centimeters. Also rotation, there was quite a change as well. At the beginning, she reported that it was easier to twist towards her left, because that's the way her lumbar scoliosis already goes. But when I asked her at discharge, she said it's much easier to twist towards her right side. So that tells me that there is definitely more symmetry, more muscular symmetry in her body. Here's a posture analysis, and you can see I used the lines on the door, so you can see quite a bit at initial evaluation. Her right shoulder is much higher than her left shoulder, whereas at discharge, she's much more even. She also appears to be leaning towards the right, and though it's not completely gone, at discharge, it's quite a bit better. If you look at the door line through her midline, she's quite a bit more even at discharge. So, clinical decision making as far as imaging goes, the American College of Radiology Practice Guidelines for Spine Radiology recommends for scoliosis, quote, an AP or a PA view of entire thoracolumbar spine. A lateral view may also be obtained. Bending views may also be obtained in some circumstances. Okay, so here's again the AP view and the lateral flexion views. Again, that were not taken with my patient, but those could be taken according to the ACR practice guidelines. And then why radiograph? Why not MRI or something else? Radiography, this is again quoted from ACR, radiography of the spine is a proven and useful procedure for evaluating the vertebra, disc spaces, facet and uncovertebral joints, neural foramina, and paravertebral soft tissues. The goal of these radiographic examinations is to identify or exclude anatomic abnormalities or disease processes of the spine and related tissues. The ACR lists indications for spine radiography, and my patient met 3 of the 13 indications, and just meeting one would be cause for radiography. So she had pain, and then also congenital anomaly, and then also alignment abnormalities. So as far as was this appropriate imaging, yes it was, according to the ACR and also according to our radiology textbook. No unnecessary imaging was ordered, and the imaging confirmed what was seen in the physical evaluation. Radiograph is the best imaging to evaluate scoliosis, to determine curvature size, height, and flexibility, as well as to assess skeletal maturity, if it was indeed a younger person, and to monitor curvature progression or regression. So again, monitoring how the spine might change as the patient ages, and that information is taken from our textbook. As far as imaging in treatment, the imaging was ordered at the first doctor's visit to confirm the diagnosis of scoliosis. So it was ordered at an appropriate time. The radiograph also enables someone to accurately measure the angle of the curvatures using the Cobb method. And what they do is they measure at the angle at the top vertebra of the curvature, and then also at the bottom, and take right angles to measure the actual angle of the curve. And then as far as did imaging change the physical therapy treatment, and I would say no, it did not. Again, I didn't get the radiograph until the second visit, and really what it did was to validate what I saw with my hands and with my eyes. So no, the imaging did not change the physical therapy management, as the patient presented with moderate scoliosis at the first session, and she also responded positively to the conservative treatment we did in the first session. She felt good. Here are the references, and that's it. Thank you.